Start.
Okay, so today we're going to talk about acid-base. And when I give this talk, I usually tell the residents, I don't really care what method you use. If you know a method to do acid-base and you're comfortable with it and it works and it's accurate, then keep using it. You don't need to do it the way I do it. There's a lot of different ways to do acid-base, but you need to know some method, okay, that works. Okay? So I'll teach you what I do, and a lot of residents seem to like it, so we'll go from there. Okay? So the first part of it is pretty simple. It's probably pretty similar to what you've always used or already know. And you might want to get a blood gas up. I don't know if you can images. Okay, so go ahead and give me a blood gas. So we'll have pH
7.22, PCO2 47, PO2,
I don't need the PO2, just the
bicarb 16.4.
Okay, so the first thing you do is look at the pH, right? And that helps you determine what at least one of the primary processes is. So you have what 722 is acidemia. Okay, acidemia and alkalemia, and the process is acidosis or alkalosis. Okay, so you have acidemia, so that tells you at least one of the processes is an acidosis, and then you look at what? You look at the bicarb and PCO2, and determine which of those goes along with that primary acidemia or alkalemia. So in this case, which is it? Both. Okay, so actually, this probably wasn't a good one to start with, but we'll go through it, okay? So you have a primary respiratory acidosis and a primary metabolic acidosis, right? Because both of them are acidosis. So basically you're done. That's why this was not a good one. So Soji, let's have a better one. Let's have one where there's a mixed disturbance, okay? So
Okay, pH 7.49, PCO2 22, bicarb 16.8.
okay, that's better. Okay, so in this case, the initial pH is 7.4, or the pH is 7.49, so that's what? An alkalemia. And which of these goes along with that?
The low CO2.
Low PCO2, so that's a what?
Respiratory.
So you have a primary respiratory alkalosis, right? That's the process. So you have an alkalemia and a primary respiratory alkalosis. Okay, so everybody knows how to do that. Every medical student knows how to do that part. Okay? Hopefully every resident, medical students know. But the next step is the part that people get hung up on. So the next step is trying to determine, is this the appropriate compensation for this? Is this the appropriate compensation? So there's only 6 possible acid-base disturbances. Okay? And these are the 6. You can have, one or any combination of them, but there's only 6. Okay, so what are these? So these are the 6. You have a metabolic acidosis, metabolic alkalosis, respiratory alkalosis, either chronic or acute, and respiratory acidosis, either chronic or acute. Okay, that's it. So if you can remember those 6 things, and and these 6 numbers, then you can do any of these problems. And if you remember them in this order, they almost go down in order, except for these 2. Okay? So, can you memorize that? That's all you have to memorize. And I usually tell people if they can memorize the Krebs cycle, they can probably memorize this. Okay? So if you learn this, you can do any of these problems. All right, so let's start with why is there a chronic and acute respiratory process, but not metabolic? What's the compensation for respiratory acidosis or alkalosis?
Through the kidney.
Through the kidneys, so excreting or hanging on to bicarb or acid, right? So the kidneys do that compensation. And how long does that take?
A few days or hours.
To fully compensate, it usually takes up to 3 days. Okay, so anything that's been going on for at least 3 days is considered chronic, and anything less than that is acute. Okay, so that's the difference between the chronic and the acute. Then how do you know whether it's chronic or acute clinically?
Compensated or not?
Well, no, I mean, before you figure it out, I mean, how do you know which of these things to use, chronic or acute? How do you know what to look? What tells you whether it's a chronic process or an acute process?
From the story.
Yeah, from their history. Okay, so if the process seems to have been going on for a week or 10 days or 2 weeks or longer, then probably it's more likely to be chronic. If it's more, it only started last night and patient was perfectly fine, yesterday, then it's probably acute. Now, that's not 100%, but that's the likely. The other thing is if they're in the hospital and they've had previous blood gases or previous bicarbs on their chem panels, you can see whether it's been going on for several days or not. But most patients, we don't have that luxury. They're not in the hospital, when we're first trying to figure these things out. So it's mostly from the history. And sometimes you have no history. Sometimes the patient comes in comatose. You have no history at all. And in that case, you can figure it out both ways. And then if it goes along with one or the other, then you could say, well, looks like this is probably an acute process. It may help you with the history. It may say this is something that probably just happened or something that actually has been going on for a while and the patient decompensated and is now unresponsive. Okay? All right, so and why is there what's the compensation for a metabolic process? What changes? Respiratory. So the PCO2 changes. So why is there no acute or chronic with that? Because it's immediate, right? You change your ventilation and it immediately changes. So there is no chronic or acute. It's all acute. Okay? All right, so how do you use this? Well, it's pretty simple. So you've identified in this patient a primary respiratory alkalosis. So what's the appropriate compensation? What changes to compensate for a respiratory alkalosis? Change in what? The question that you're asking is what should the what be?
The kidney should be retaining.
Okay, so it should be a change you're looking for a change in the bicarbonate, right? So the question is what is the change in bicarbonate? What should that be? Is this the appropriate amount or not? So you say change in bicarbonate equals change in PCO2 times the factor. Okay, in this case, what's the change in PCO2? What's a normal PCO2? 40. Okay, and I know there's a range, but for these problems, you use 40 for the PCO2, and what's a normal bicarbonate? 24. Okay, so you use 24 for the normal bicarbonate and 40 for the normal PCO2 for these problems. Okay? All right, so the change in PCO2 from normal is what? 18, right? PCO2 is 22.
Oh, sorry. Okay, PCO2.
Right?
Yeah.
So 18, and it's a primary respiratory alkalosis. So we look down here, and is this chronic or acute? I don't know. I don't know who this patient is. Soji, is this acute or chronic?
Acute.
This is acute?
Mm-hmm.
Okay, so this patient has an acute process. So we look at acute respiratory alkalosis, and what's the factor? 0.2? So what is that, 3.6? So the change in bicarbonate should be 3.6. So it should be 24, and it would go which way? Normal compensation. Be acidosis, right? So go down, so it'd be 24 minus 3.6, so about 20, right? So the bicarb should be about 20. And what is it? 16.8. Usually it should be within like 1 or 2. So what does that tell you? It's more than that, right? Because technically this is 20.4. So you're almost 4 apart. So what does that mean? It's lower than you would have expected for normal compensation. So what does that tell you?
Chronic.
No, it tells you that there's a superimposed metabolic acidosis because the bicarb's lower than you would expect.
What are the alkalosis?
Metabolic acidosis because the bicarb is lower than you would expect it to be 20 for normal compensation, but it's 16 or 17, right? So it's lower than you would expect. That's more acid than you would expect, right? Or less bicarb, more acid. So in this case, you have a primary respiratory alkalosis and a primary metabolic acidosis. Now, if this were a chronic process, if Soji's wrong and this isn't acute, and we figure it out with 0.5 instead of 0.2, what do you get? You get 24 minus 9, right? 18 times 0.5 is 9, half of 18. So you have 24 minus 9 is 15. It's pretty close. So maybe this is more chronic than she thinks. I don't know. She said it was acute, so we're going with that. Okay? So let's do another one. So always put what you're looking for on the left side of the equation. Always put what you know on the right side of the equation. Okay? So always put what you're looking for the compensation on the left. So if it's a primary, this was a primary respiratory alkalose respiratory process, so we were looking for change in bicarb. If it was a metabolic process, we'd be looking for a change in PCO2 for the compensation. So we just say change in PCO2 equals change in bicarb times the factor. Just flip it. Okay? All right, so let's do another one so you get the hang of it.
P hit 7.40.
40? Oh, don't do one with 40.
39.
39? Okay.
PCO2 28. Bicarb 16.9.
16.9?
9.
So you have a primary, you look at the pH, and what do you have? An acidemia or an alkalemia? Acidemia. And is this a primary, at least one of the processes is going to be what? Primary what? Metabolic acidosis. Okay, metabolic acidosis. So what's the compensation for that? What are you looking for a change in what? To compensate for a change in PCO2 equals a change in bicarb times the factor, and the change in bicarb from normal is 24 minus 17, so 7. And it's a metabolic acidosis, so it's 1.2, 8.4. Right? So the change in PCO2 should be 8.4. So 40 minus 8.4 is 31, 32. And what is it? 28. So what does that mean? It's about 4 off. So it's a little lower than you would expect. So what does that mean?
There's a respiratory acidosis.
Respiratory alkalosis, because it's lower than, the PCO2 is lower than you would expect. So you have a primary metabolic, so you have a mixed disorder. Whoops. There's that. A primary metabolic acidosis and primary respiratory alkalosis. Okay? We'll do one more. Another one?
Do you want with anion gap or without anion gaps?
We'll get
That
to anion gap
later.
You can, it
There-
doesn't matter either.
There are no alkalotic pHs here. I mean, like without
Everybody with a
bicarb
primary
is like.
alkalosis.
Oh yeah, one of our patients had it actually. Who had it? Daniel Gill. She had
Yeah,
alkalosis.
okay.
Yeah, alkalosis.
Yeah, she's had a lot of
Yeah.
alkalosis. Okay, so
I'll
what
get
does she have? Give me one.
It's loading. So pH 7.53, PCO2 31,
31,
mm-hmm.
bicarb.
25.9.
Okay. So we look at the pH, and you have a alkalemia, and so that means at least one of the processes is an alkalosis, and what would that be? Actually, they're both alkalotic, right? This isn't a good one. Because they both, so you have basically a primary respiratory and a primary metabolic alkalosis, because they're both going in the same,
Okay, one more.
coincide with the pH.
7.52.
752,
Yeah.
okay.
43.
Okay.
32.
Okay, so we have an alkalemia again. And what goes along with that?
Bicarb.
Okay, so what kind of alkalosis do you have?
Metabolic.
So you have a primary metabolic alkalosis and
And a respiratory acidosis.
you have a respiratory acidosis. Well, the
But
question
then-
is it appropriate compensation, right? So is it or not? So you're looking for a change in the PCO2 equals the change in bicarb times the factor, and the change in bicarb metabolic alkalosis. So change in bicarb is what? 8. And the factor is 0.6. So this is 4.8. So you would expect the pH or the PCO2 to go up or down by 4.8. Up to compensate, right? So that would be like 4 to 5, right? And it's 43, so it's pretty close. So it's basically a compensated. So this patient has a appropriately compensated primary metabolic alkalosis with respiratory compensation. Okay, any questions about this so far? Okay, so the next step, once you've figured out the primary processes, is to figure out why they have those what is causing those processes, okay? So this is, fun and interesting, but really the bottom line is, if it doesn't help you take care of the patient, who cares? So you really need to figure out why do they have these processes, what's going on, and can you correct those, or what do you need to do to correct those? So if you have a primary metabolic acidosis, what's the next step in evaluating that patient?
See, looking for a gap.
So looking for the anion gap. So what is the anion gap? What causes the anion gap? What is it? First of all, how do you calculate the anion gap?
Take the sodium minus the sum of the chloride and the potassium.
Bicarb.
Bicarb, sorry.
Right? So what is a normal gap? How much?
10.
Okay, so it's 10 to 12. It's probably closer to 10 in reality, but for your boards, always use 12, because they always use 12 on the boards for this. Okay? So but it is probably 10 to 12, and it's probably closer to 10. So what is that? Why is there an anion gap? What is the gap? Causes that?
It's the unmeasured anions.
Unmeasured anions. Okay, so what anions aren't we measuring in this equation?
Glucose.
It's not an anion.
Lactic acid, alcohol.
Urea.
Well, those things are, urea is not an anion.
Sorry. Albumin.
Ketones.
Albumin.
Negative.
Okay, so albumin is a large part of the anion gap, of the unmeasured anions in the anion gap. So albumin. Okay, so proteins, most proteins are negatively charged, and that constitutes a lot of the gap. So it's important to adjust the anion gap for albumin. So if you have somebody with significant hypoalbuminemia, that can mask an anion gap. So do you know what the correction is for that?
For 1 drop, you add 2.5.
Okay, so for every 1 gram of albumin, the gap, you have to correct the gap by 2.5. So if you have somebody with an albumin of 2, which is pretty common in the ICU, right? Everybody's albumin is low after a day or two. You get all this fluid and everything else, right? You actually have to adjust the gap by 5 in a patient with an albumin of 2. So if you have somebody and you calculate their anion gap using this equation, and it comes out to be 12, but their albumin is 2, well, their actual gap is probably 17. So they have an increased gap. Okay. All right. So what else is part of this gap? There are other unmeasured anions. Come on, you look at them every day on the chem panel.
Phosphates.
Phosphorus is one. Sulfates, which is another. Nitrates. Calcium's the cation, right? But you're right. I mean, what about unmeasured cations? We're not measuring. How come that's not in there? What about potassium? Why isn't potassium in this equation? Why should it be all cations minus? I mean, it should be all cations minus all anions. Why don't we put those in the equation?
Intracellular.
I mean, you're measuring them in the serum. They're not intracellular. Magnesium, another one, right? Sodium, magnesium, calcium. These are all cations. Don't see it in there. When I learned the anion gap, we used to include potassium, and the normal gap was 16. This normal potassium's 4, right? So the gap, normal gap is 16. So I don't know the answer to the question as to why we don't include all those other things, other than to say that this was probably developed many years before they routinely measured these anions that we do on chem panels now. They didn't have chem panels. They had to measure each electrolyte individually back then. It was even before my time, okay, probably 50, 60 years ago. And it was hard. They didn't have good ways to measure certain anions and cations, so they didn't do them routinely. They were very complicated. Now we just do them on these panels and they're done. You know, it's all automated. It's very quick. So, but I think over the years they found that adding all those other electrolytes into this whole theory or this whole scheme didn't add anything to the utility. It didn't really matter. This was enough. You know, if you added calcium and potassium and magnesium and nitrates and whatever, sulfates and phosphates, it really wouldn't change the end result of the analysis. So why make it more complicated than it needs to be? It's a lot easier just to add 3 numbers or subtract 3 numbers. Okay? So, but the important one to remember is albumin. You really need to adjust for that. Okay? All right, so what are the causes? If there's an increased anion gap, what does that mean? It means there are other additional unmeasured anions, and that means there's some other types of either endogenous or exogenous acid in the blood, right? So you have, HA. Right? Okay, so what are those other anions? If you have it, so what are the causes of an increased anion gap acidosis?
Mud piles.
Pardon?
Mud piles.
Mud piles. Okay, so that's the mnemonic which pretty much everybody learns. I've only heard one or two other ones, but I always forget them. So most people know this one. So what does it stand for?
Methanol.
Okay, methanol.
Urea.
Urea.
DKA. Acetone or something.
Polyethylene glycol.
Formaldehyde. Now, I think polyethylene glycol is probably one of them, but I'm not 100% sure. You can see that in some, where do you see that? When would you ever see that in the blood? Do you know?
When drips, especially when people
What kind of drip?
Versed. I don't know if Versed has it or
Not Versed. Close. Ativan.
I didn't know.
So lorazepam is in a vehicle, it's polyethylene glycol is in the IV formulation. So in single injections, it's not a big deal, but if you have somebody on a continuous drip of lorazepam, this can actually build up, and they basically, this is very similar to the E. What's the E on here? Ethylene glycol, which is what? What is ethylene glycol?
Antifreeze.
Antifreeze. It's antifreeze. So this is very similar compound, right? Okay. So they both can cause an acidosis, a metabolic acidosis. Peraldehyde was the original thing in here in this mud piles. Peraldehyde, do you have any idea? No one in here has ever used it or seen it or heard of it probably. I've never actually used it either, but it used to be used for alcohol withdrawal. All I know is it supposedly tasted really bad. So it was kind of punitive when you gave it to the alcoholics to drink. I guess. I don't know. Okay, what's the I? Okay, isonize it. Anything else? Also iron overload can do it. Okay, and what's the L? Lactic acidosis. And the S? Salicylates. Okay, so if you have somebody with an increased gap, then you should go through this list and try and figure out if any of these might be causing the increased gap acidosis. Sometimes you have more than one. DKA, also you can see with any kind of ketoacidosis, right? So alcoholic ketoacidosis, starvation ketosis, not usually as severe, but you can get that too. It's usually a mild acidosis. How do you rule these out? Well, peraldehyde you can probably pretty much forget about. Polyethylene glycol, unless they've been on a drip of something for a while, probably don't need to worry about it. DKA, you can look for ketones in their blood or their urine, or both. Uremia is pretty easy to figure out from their chem panel. This you have to get from the history. Lactic acidosis, you can measure the lactate. Ethylene glycol, how do you diagnose that?
Osmolar gap.
Okay, so you can do an osmolar gap. What else?
Urine.
What do you look for?
Urine.
What do you look for in the urine?
Those crystals.
Those crystals, what kind of crystals are they? When's the last time any of you ever looked at a urine under a microscope? Have you ever looked at a urine under a microscope? Do they even teach that anymore? No.
I looked when I was in med school, but
We used to have to do all our UAs. Okay, so you look for the calcium oxalate crystals. Okay, and they're sort of envelope, right? Sort of envelope shaped, like little X's on there. So we look for calcium oxalate crystals. You can also look at the urine, I think, under a Woods lamp, and it can fluoresce because you know how ethylene antifreeze is that fluorescent yellow-green color. You can see that color some in the urine if you look with the UV light. Okay, so what about methanol? How do you diagnose that?
Any visual problems? I mean, apart
Okay,
from...
so the classic person with methanol overdose is blind and drunk, right? So they get, what kind of eye problem do they get? What does it do to the eyes? No. It causes an optic nerve neuritis, and you can get pale optic nerve, so you might have to have an ophthalmologist look in there, or do a fundoscopic exam. And then they act drunk, and you can look at their osmolar gap. And then salicylates you can measure, right? But you have to know to look for it, right? It's not routinely measured, just like lactate, ketones, and these other things. So if you have somebody with an increased gap, you need to go through this list. You need to order the appropriate tests if you're not sure of what's causing it. Okay? This is not an exhaustive list. There are other things that will cause an increased gap acidosis. And I always tell residents that this is probably 95 or 98% of all the ones you'll ever see will be on this list, because these are just really common. But there are rare causes that aren't on this list, and you need to go and look for those. And we have occasionally had people with severe acidosis due to other things that was not on this list. And if we had not done that, we would have probably not treated the patient appropriately, and they probably would have died. Yeah.
So if someone comes with uremia and then acidosis is not just because of uremia and we need to find others, either we have to order everything, or is there a way that how much of urea increase causes how much of anion gap? Is there a relation between ketones similarly?
There is a relationship, and we'll talk about that when we talk about the delta-delta gap.
Okay.
But I only know of the relationship with keto acids and lactic acid,
Okay.
not with the other ones. I don't know exactly what that relationship is. Okay, is that it for this? Okay, and what about a normal anion gap acidosis? So notice how I didn't say non-anion gap, because it's normal to have, at least by this equation, an anion gap, right? We said the normal is 10 to 12. So what about people who have a normal anion gap acidosis? What's the differential? Hard up. Okay, so that's the one that most people seem to know. I have another one that I learned that was different than that, which is has a few more things in it. I don't think we go through that. The one I know is, and they're similar. Pure hand. There's a couple other things that's not in this list. So since you brought this one up, what's the H?
Hyperchloremia and hyperalimentation.
Hyperalimentation and I ran out of room. And hyperchloremia. Okay, what's the A?
Acetazolamide.
Okay. Diamox. Zolamide. Okay.
RTA.
RTA.
Diarrhea.
Diarrhea.
And then the last two, I don't remember, some kind of shunts, like urido.
Sigmoidostomy.
Yeah.
So ureteral diversions. And what's the P?
Pancreatic fistulas.
Pancreatoduodenal fistula. So if you look at this list, it's very similar. The only thing that's different, so there's the P, the U, the R. E is not on your list. Okay, so E is actually early renal failure. And that's actually a pretty common one that we see. So you should really remember that. Okay, early renal failure. And then the other one is the N, which is ammonium chloride. So people have received ammonium chloride usually for treatments, which is, you give it because it's an acid, right? So you're going to develop an acidosis. But all the rest of these are the same as what you have on this list. And usually, you know, based on the history and the physical, you can rule out some of these things. I mean, usually you know if they have a ureterosigmoidostomy. You know if they've gotten acetazolamide. You usually can figure out that they do or don't have a pancreatoduodenal fistula. So that you're left with three things. You're usually left with early renal failure, diarrhea, and RTA. Okay? And I know you guys just had a patient with RTA that you worked up. So how do you work up RTA?
Urinary.
Okay, so urine anion gap. And if so how do you do a urine anion gap?
The same electrolytes but in the urine.
Okay, and then how do you interpret that?
If it's positive or negative,
Okay, and if it's positive,
then it is RTA type 4. That's where I get confused.
if it's positive.
Actually, it's little different. You have potassium here, sodium
Right, you do
plus
have
potassium.
also.
You don't have bicarb, and whatever you calculate is for the bicarb actually. The gaps you calculate for bicarb. So positive means there is less
So
of
tell me what it
bicarb.
is. Soji? So you
Sodium
have sodium,
plus potassium,
so we're going to put urine
anion gap,
anion gap equals sodium
plus potassium
plus the potassium
minus chloride.
minus the chloride. Whoops, sorry. Right?
Mhm.
And if this is positive, then what does that mean?
Which means that there is less bicarb,
Okay.
which means kidneys are absorbing bicarb. So it's not the problem with the kidneys, but something else other than the kidneys. And if it's negative, it means that they're urinating a lot of bicarb.
Uh-huh.
So kidneys are not functional there. So it's negative means more of kidney
I
problem.
thought it was the other way around.
Yeah, I think it's backwards.
Oh.
I think you got it backwards. I think if it's positive, then you have an RTA, right?
Oh, sorry. Yeah.
It's the
Sorry.
other way around.
I'm sorry. Yeah.
And if it's negative, then it's not,
Mhm.
right?
Yeah.
Okay. And then, so I'm not going to go into all the evaluation of different types of RTAs.
But you can't tell the different types of RTAs by the urine anion gap, right? You just tell if it's diarrhea or renal.
Mm-hmm.
Yeah.
Okay.
I mean, I think in order to determine type 1, type 2, type 4, type 4 is hyporenin, hypoaldo, so those patients usually have hyperkalemia in addition to the acidosis. And most of the time they're diabetics, because it's very common in diabetics with diabetic kidneys, but not exclusively. Okay. The other two types, type 1 and type 2, I think are harder to sort out.
They can do a bicarb challenge test actually.
Right, so you can give bicarb and see if they respond or not. One type responds, and one type doesn't respond to bicarb because it's just dumps all the bicarb that you give.
Yeah.
And
Type
that's
2.
type 2. Yeah. Okay, so talked about metabolic acidosis, increased gap, calculating the gap, albumin corrections, differentials for the gaps. So what about metabolic alkalosis? How do you evaluate that? Just like in the metabolic acidosis, you look at an anion gap, how do you evaluate a metabolic alkalosis?
Saline responsive.
How do you determine that? Whether it's saline responsive or unresponsive? What tests do you do? What's the branch point? So you do a urine chloride, right? based on the urine chloride, then it breaks down into either chloride responsive or chloride unresponsive. So those are the two differentials, just like when you break down the anion gap into increased gap or normal gap. So what's the cutoff for the urine chloride for this?
20.
So here, depending on where you read, you're going to read different things in different books. Your little red book that everybody carries around, although yours is green. I don't know why. Is that a newer version?
I haven't gotten
no.
that book yet.
You haven't elevated from student to intern yet. Is that it?
It's a combination of
Well,
the
This
that's the
has labs.
GAPFLY guide. That's
This
why.
guide,
Okay. So the urine. So in that guide, it uses 20. Okay, as the cutoff. So if it's less than 20 or greater than 20, right? It's less than 20 because if you're not putting chloride out into the urine, you're hanging on to chloride, then the kidneys are doing that usually because they are trying to maintain intravascular volume and they're holding on to sodium and chloride together, right? So that's why the chloride excretion in the urine is very low. Whereas the chloride unresponsive, you're peeing everything out. So in that guide it says 20. Other places you'll read 20 and 40. So less than 20 or greater than 40. Probably this is more accurate. It's probably because there's never a hard and fast one number cutoff for anything, right? There's always a gray zone. So there's probably a gray zone, between 20 and 40. But certainly if it's much less than 20 or much more than 20, that's going to help you. Okay, so what are the chloride responsive causes of chloride responsive metabolic alkalosis?
Like vomiting.
Okay, so
diarrhea.
vomiting. What else?
Diarrhea.
What does diarrhea cause? We just went through diarrhea, right? That was on another list.
Oh, that's an
Non-M gap.
acid.
Causes of metabolic,
Acidosis. It was by
normal
carb.
anti-gap metabolic acidosis, right? So vomit, diarrhea is not on this list, okay? So vomiting, what else?
Suction. NG2.
Okay, NG suction, which is kind of the same thing, right? You're losing chloride and acid through the NG or through vomiting. What other things are there?
Diuretics.
Good, so diuretics, and usually late, chronic diuretic use. So they say late, which is really chronic. Okay, what else? You have the whole list in front of you,
Yeah.
cheating. Okay, give me one.
Cystic
Should I just do it?
fibrosis.
Cystic fibrosis, refeeding. Is that on the list? Cystic fibrosis. Refeeding. What else? There's more on that list.
Volume depletion.
Okay, so volume contraction.
It says even laxatives here. I
Yeah,
don't know.
laxatives.
Villus-adenoma. And post-hypercapnia.
Yeah, so post-hypercapnia. And villus-adenoma. Okay, and what about chloride unresponsive?
Hypertensive or hypotensive. That's what
What?
it breaks down to. The blood
The what?
pressure. Hypertensive or hyponormotensive.
Oh, so on there they break it down into blood pressure. So if they have hypertension, then they have what? They have increased aldosterone or increased mineralocorticoid or glucocorticoids. Right? Okay, so you have glucocorticoids and mineralocorticoid. And on the normal blood pressure,
Diuretics.
So you have early diuretics. What else?
Oh, both cause diuretics. Okay.
So this is usually late, like chronic.
Okay.
Early diuretics you can develop.
Severe hypokalemia.
Severe hypokalemia, usually the potassium has to get down to like less than 2.5. So severe hypokalemia.
Exogenous alkalis.
Milk alkali syndrome. We actually had somebody with that recently, which I had never seen before. Milk alkali syndrome. And then there's Barter's and Gittleman syndrome, which nobody ever sees either. Okay, so again, I don't know that these are exhaustive lists either, but likely it's going to be on this list if they have it. So how do you treat it?
Well, the saline responsive you can get.
Saline. Right, chloride, saline. And the other ones, they're all different treatments depending on what the cause is. So, and that's the whole point of trying to figure this out, because you want to know how to treat the patient, right? So unless you can figure out what the cause is, you don't know what the best treatment is for it. And you can, if you take somebody that has chloride unresponsive metabolic alkalosis, you can give them all the saline and potassium chloride you want in the world, except for maybe this person who needs potassium, and it's not going to correct. You can just keep coming in day after day after day, and nothing will get better. So that's really the whole point of all of the acid-base stuff, is trying to figure out what's the underlying problem, and then how do I treat that. And a lot of times you'll find things that you didn't expect just by going through this. You will find, syndromes, entities, problems that were never on your problem list, you hadn't even thought about until you figured this out. You narrowed it down to one or two things, and you go, gee, maybe they have this. I didn't even think about that. Okay. All right, well, I think we'll stop there. And then maybe tomorrow we'll do the delta gap, which is sort of the last part of this talk. Okay? Till tomorrow.